Welcome to VNEW Health, powered by Arms Medical, where we explore key topics shaping women's health today. This episode is brought to you by Super Patch, committed to enhancing the well-being through innovative solutions. I'm Robert Greer, and joining me today is Dr. Barry Jarnagin, respected urogynecologist from Nashville, Tennessee. He takes a patient-centric approach, and he works at the Williamson Health Urogynecology and Pelvic Health Center. Dr. Jarnagin helps patients navigate through various pelvic health challenges, and today we're focusing on the second episode of menopause, what it really means for a woman's body, and we're going to be diving into the clinical data. A lot of misinterpretations, and we're going to unpack it coming up, and so we're looking forward to having Dr. Barry Jarnagin. Welcome to the program. Welcome back to VNEW Voices, powered by Arms Medical. Back in the studio for the second session of talking about menopause and women's health, Dr. Barry Jarnagin, urogynecologist from Franklin, Tennessee. Dr. Jarnagin, welcome back to the program.
Thank you for having me back. I really appreciate it.
We left off last time talking about a particular article that was published that you and I had referenced. We spoke, and your comment to me was that it was changed the way medicine was practiced and how they looked at prescribing hormones to women. Can you I'd really like to dive into that and unpack that particular study because it really had a large impact on how women were managed.
Yeah, it had a huge impact. We're referencing what's known as the WHI Study. It was back in circa 2002. And the thing that really hit was the USA Today picked up on that and put in headlines, front page news. I wish I still had it. Hormones kill women.
Right.
And
That's like at the title.
Yeah, it absolutely scared women, providers, etc. And up until then, there had been a lot of data, probably Premarin, which is a bimouth estrogen hormone, probably is one of the most studied medicines ever in the USA. I mean, it had been studied, and there was a lot of data, which I hope we can maybe get back to at some point. But, and largely the majority of the data was positive. And it was so positive that there were cardiologists that had picked up on it and said, you know what? Hormone therapy may actually reduce the risk of cardiovascular disease. And
Cardioprotective.
Yes. So the whole WHI study started out as, can we prove that hormones will, in fact, reduce cardiovascular disease? That's how it started. That was its premise. That was its primary endpoint. And then I forget how long the study went before it was abruptly stopped because they saw a increase in breast cancer. Now, that increase in breast cancer went from like 2 in 10,000 to 4 in 10,000. So technically speaking, it was doubled, but it was still a small number. The other thing was the way the study was designed, and that is it was all comers. So you were 50, you were 80, it didn't matter what your age was.
Inclusion, exclusion criteria. It grabbed everybody.
And it was intent to treat study, which simply means that if you enrolled in the arm of hormone replacement and you started taking it, but then you quit because of a side effect, you still were in that arm. So your data point was measured in that arm, even though you may have only taken it for a few days or a month. So understanding the parameters of the study was important. But it came out, and so it was abruptly stopped. It never was finished. And it made the headlines, and I studied the study itself and read it. And at the time I was known for hormones, I was known for menopause, and I got asked repeatedly to go across the state and lecture on menopause and the WHI study and what it meant, etc. And I gave about 5 lectures across the state to primary care, PA, state association, nurse practitioner meetings, large organizations, 1,000 people in the crowd. And I started every lecture the same way. My first question was, how many people have changed their prescribing habits based on the WHI?
The whole room.
95+%. It didn't matter whether they were PAs, NPs, MDs, DOs. It didn't matter what their specialty was. Every single one, 95%. Then I asked the second question. How many people actually read the study? And I'm ashamed to say, again, across all of them, only about 5% actually read the study. And so they based their entire change of prescribing habits and their view on hormones based on a USA Today headline.
Yeah.
Problem is that also has transcended, because those people that were impacted that changed their prescribing habit also went into becoming faculty and teaching students. And so this is now generationally passed down as hormones are evil.
That's right. High risk.
And so, but if you go back and you look at the study, and they have now gone back, and this unfortunately has not made the USA Today headlines. It did not make front page news, but they've gone back and looked at it, and they've done sub analysis of it, and they realize that if you start hormones at the appropriate time, i.e., within 10 years of menopause, they've not been shown an increased risk, as long as you don't use the synthetic progesterone that was utilized in that study. And so there has been no other study shown where hormones outside of that one synthetic progesterone increase the risk of breast cancer. Moreover, looking at the WHI, the one the USA Today put in headlines, estrogen only actually was trending towards benefiting breast tissue and actually reducing the risk of breast cancer. It didn't meet statistical significance because the study didn't go out that far. But so the bottom line is, even that study, when dived into, never really proved that there was an increased risk in breast cancer, other than the one arm of estrogen and a synthetic progesterone combination.
But if you teased out the data, and to your point, the inclusion, exclusion, they were still enrolled, they took it for a week, they stopped, but they were still followed. And if that person then had breast cancer, now it was recorded.
Right. Exactly. Yeah.
It's like saying,
exactly.
hey, I went to your office. I had you did a consultation for surgery. We put it on the calendar. I didn't show up. I'm still in the study.
Yeah.
Did my surgery fail?
Yeah. Right. That's right. Yeah. Exactly. No, it's exactly right. So the data of the study has all been, again, essentially debunked and or at least modified to appropriate levels. But unfortunately, that data has not made the USA Today headline, because good news doesn't sell, right? And so so that data and that information is not out there for the common population or the common provider. It's just simply minimized, and we went from pre-WHI of a majority of women getting on hormones when they hit menopause to a small minority of women. The last thing I saw was less than 10% of women in menopause who are eligible for hormones don't only take them, only 10%. So we've gone from 80+% to 10% or less, all because of that one study.
So what do you think, what needs to change? I mean, I know we're doing this podcast and, hopefully we can get 10,000 views on it and we can get the word out that in the right patient population, which seems to be almost everyone, except, those that you could maybe tease out some people that you wouldn't do it for. I think people would be curious of how you thought about that, but what can be done because of all the things that we talked about in the first session of what happens to, osteoporosis, cardioprotection, sleep, mood, all these different comorbidities. What do you think we can do as a medical community to change that behavior?
We're doing the podcast. We're trying to get the information out there. We're trying to educate the population. The population needs educated because, at the end of the day, the patient is the best person to promote herself, right? When she walks into the office, here's what I want and need. And if you're not going to give it to me, I need to go find somebody, number one. But number two, we got to get this podcast out to the providers. We need to get this out to the family practice doctors, the internal medicine doctors, the general OB-GYN doctors that have this bad view, inappropriate view, and inappropriate information that has been just kind of passed down generationally. It's like the old child game, where you start a rumor in the front of the classroom, and then by the time it gets to the back, it's totally different. And so, this is kind of one of those where bad information has just been passed down along, and it's that cycle has to stop. But we also have to get it into the academic centers.
That's exactly it.
Because medical students, PA students, nurse practitioner students,
they're on the front line.
Residents, as they're learning, they need to learn the real information, and that's where we need to get it to ultimately. And the problem is, I have taught in OB-GYN residencies, I've taught in family practice residencies, I've given lectures in PA and NP training programs. The problem is menopause is not high on the educational cascade. And so when you're doing a X period of time training program, whether that is 4 years of medical school, 4 years of residency, or 2 years of, PA or NP, regardless, what that segment of time, the amount of time that menopause gets is minimal.
So hopefully you weren't on call the night before and you're off.
Right. Or you had an emergency case, or
right.
You were sick that day, or and how much impact a lecture be if you don't take it into your clinic setting and you don't practice it in your clinic setting before you go out. So you got to have those trainers geared up so that they offer patients good information and train so that people can learn, because you're going to learn more by doing than you are by hearing. So it's unfortunately a big problem. Getting word out to patients is vital. they have to be their best advocates, getting the word, but we got to figure out how to disseminate it amongst providers.
So if I'm a patient, I'm listening to this, and now I know that I go to my family practice. I'm menopausal. Uh, what would that message be to the family practitioner? How do you message that so that you can start heading down this pathway?
I think you have to ask how how much active menopause treatments do you offer? What's your belief system in hormone therapy? And can we work together collaboratively so that I can uh, be taken care of appropriately? I think those are the things, because if the person is not interested in menopause, then you need to find somebody else that's going to talk to you.
I think the fourth question then would be, and if this is not in your wheelhouse, who would you recommend me to see? Right. And I mean, I know that, I mean, you do telemedicine, um, certainly could be an option, but I don't think there's enough hours in the day for you to manage the country as busy as you are. But, that's really that. So those three questions, plus then the final one of, okay, who would you recommend me to see?
I think that's right. And then you got to really question, how they treat them, because um, some some providers will treat them for up to, I can't tell you how many patients I've seen that, and I'm like, so, and they obviously have um, vulvovaginal atrophy, and their tissues are thinned out, and they're suffering significantly. And I go, when did you go through menopause? Did you ever do hormones? And it's very common. Well, my provider allowed me to use them for 5 years and then stopped them. And then I'm like, okay, well, why did they stop them? Because they said that was how long you were supposed to take it. And again, that's where our leadership, if you will, at the time, the Menopause Society knee-jerk reacted right after the WHI and came out with, okay, well, treat it, but treat it for a shortest period of time possible, and no more than 5 years.
And that's the Menopause Society.
Yeah, and that was based on zero data. It was pull something out of the air and put it out there. Zero data. It didn't have data then. It doesn't have data now. It was bad messaging. It was bad information. And that's that has been disseminated out. And so women may or may not be able to get it for up to 5 years, and then they suffer. And so when women are evaluating where to go, they have got to talk to providers of, what is your belief system in hormones? Because I need somebody who's going to manage my menopause. Menopause is from the day my ovaries quit working. 51.7 years is average. Could be earlier, could be later. I need to know who's going to manage my menopause from when my ovaries quit working until the day I die, because that's my menopausal period. I'm in menopause that entire time. I'm not in menopause for 5 years or 3 years or 1 year.
I didn't get through it. I'm not through menopause.
I'm living in it now, and it is going to affect my body. And so, how are you going to help me throughout the entire time period? That is who you need to be seeing. And you need to be seeing somebody who understands the data, understands, and will go over risk benefit data and that sort of thing.
Where would you put your high risk patient? Who's your high risk patient?
So obviously you worry about the lady who is estrogen positive for breast cancer. If they have a breast cancer that's estrogen positive, that's a difficult patient. And that that may require a whole nother podcast. But that's a difficult patient. And then under that, you have the patient, they've been away from hormones for 10 years or greater. And so the studies are pretty clear. You need to be put on systemic hormones within 10 years of menopause. And the reason why after that has nothing to do with the breast and has everything to do with the heart. And so what we know, or what we think we know in 2025, is that estrogen actually does protect the heart. And so what transpires, which is something that, as an old guy, these are the studies that were being done way back when. There was a guy who did a lot of hormone data looking at heart, bone, jaws, neurons, the brain, etc. And now there's all of this data that's coming out now that is basically confirming everything he put out 30 years ago, right? But so it is cardioprotective. It does, if you are a reproductive female, you have less risk of developing plaque in your arteries. Okay, and so men are going to develop plaque because we don't have as much estrogen in our body that women do not. You hit menopause, and then if you don't do hormones, your arteries start turning into men's arteries. They start developing plaque. And so what happens, the estrogen actually starts to treat the vessel. So if you go 10 years, you've got all this plaque built up, you start back on hormones, and then you start getting it to dissolve, it flicks off, and you have about a year of increased risk of heart attacks and strokes. And so you got to warn those patients that this is a risk. It's a known risk.
Okay. And so that's at the 10-year mark.
But I've got patients who come in at 11, 12, 13, 14, 15, and they go, I don't care. I'm miserable. Let's do it.
Right.
And so we start.
So do you just start slow then? Slow and low?
We start, because you tend to use bioidentical hormones.
Right.
And I titrate them, I can start low and slowly work my way up. Now, there's no data to say that that's any safer than anything else. However, it makes sense that it would be safer, and sometimes common sense does actually work. And so, knock on wood or whatever we have around, I haven't had any patients that have had any problems by doing it that way. But they have to know. They have to know what the risks are. Now, alternatively, we can treat the symptoms of menopause in somebody who's 15 years out, without going through that kind of risk. We can treat their vaginal tissues with local estrogen, and local estrogen has been deemed and studied and shown to be safe and effective. So we can reduce the issues as it relates to vulvar vaginal atrophy by using localized therapy. And then you have to treat the other symptoms with other kinds of medications and or behavioral therapy. Cognitive behavioral therapy actually has been shown to be good and helpful in menopausal symptoms related to hot flashes and mood swings, etc. And then there are other medications that are non-hormonal that we use for those type symptoms too. So you kind of treat the symptoms of menopause without giving them back their hormones.
That would be for what type of patient?
That's for the lady who's 12, 13, 14, 15 years out who needs treatment for their menopause.
And you don't want to put them on or they don't want, honest.
They're not willing to take that risk of increased risk of heart attacks in that first year. So we don't do systemic hormones. And that's when you have to have that conversation of, okay, you've been out for 12 years. Here's your risk if we start systemic hormones.
And what is that risk?
Yeah, heart attack.
Yeah, but what's the percentage?
Flicking that plaque. That's a great question, and I don't have an exact number. It's just kind of been out there that it increases the risk, but it's not a huge risk. But it's an increased risk over what she otherwise would be. Now the question becomes, which I don't have an answer for. The question becomes, because we know estrogen makes the arteries healthier,
Right.
if they go on it and if they survive that year and they don't have a heart attack or stroke, and they do treat their plaques with hormone therapy, do they then start benefiting cardiovascularly from being on the hormones? And I don't have an answer for that. I'm not suggesting yes or no. I'm just saying, from a pure physiologic point of view, it could be. It could be. But that's kind of a hypothesis that's out there that just kind of conversation wise. But for that person who's after 10 years who doesn't want to go through that risk, then again, you treat locally, you treat with other medications to try to reduce the symptoms. And then you can add in cognitive behavioral therapy, etc. And then there's other things that people talk about, change in, you turn your heat down in your home, and you increase the air conditioning in your home, or,
Right. Environmental
you
scenarios.
So environment, cognitive therapy, and then medications and local therapy, hormonal therapy, and medication. So I think
But wouldn't it be better, though, to just transition them from when their ovaries stop working to put them on a hormone replacement?
Oh, absolutely. Yeah.
Why are we trying to make so much work out of this?
Well, the problem is there's those women who were told wrong,
Right.
treated wrong,
Which
they're
we're dealing with.
by no fault of their own, they're behind the 8 ball, right?
100%. 100%.
But
we want to have a program, but let's just think about we're gonna take care of these ladies with different treatment options. But let's go back to the fact that, even in my group, because I'm in that age group, the number of people that are highly educated people that, 4-year degrees, master's degrees, doctorates, that are not on any hormone replacement.
Oh, absolutely.
Because they will say, I'm concerned about cancer.
Yeah, absolutely.
So that information is still in our circles.
Female physicians in my practice who came in with the wrong information on hormones, because that's what she had been taught. That's what she had. That's the only information she had been given, and she had no idea. And the problem is treating fear. I've got women who I will sit and I'll have a 30-minute conversation with them, and then they'll go home, and then they'll talk to Aunt Susie, or they'll go to their church group and they'll talk in their church group, and I'll see them back in a couple of months and they won't have any change. And I'll go, what happened? And they go, well, I just never took the medication. And I go, well, why not? And well, Susie said it caused cancer. So regardless of what I said for 30 minutes and trying to talk to them, obviously, there's somebody out, one of their friends that knows a lot more.
So for all of these ladies that are watching this podcast, okay, I'm bringing to you one of the most foremost experts who has done this just because he's passionate about his space, to understand. Do not go back to your cousin, auntie, uncle, friend, sister, boyfriend, doesn't matter, okay? Because this is what we do. We bring real facts, real science with the experts like you, Dr. Jarnagin. I think that's a really good place to finish this off today.
I think the value, there's not many benefits of getting older, but one of the benefits is I have been able to study hormones for, I mean, seriously, 30 plus years. And so I don't have just one data point on a graph. I have 30 years of data points in a graph and have a lot of information. Now, the other thing, which I just will say, I'm trying to, and maybe next time we talk, I'll have more information, and maybe you can help me with this. But I'm trying to come up with a regular weekly broadcast to talk to women and that sort of thing, and try to more and more get the word out and try to help women.
No. Listen, that is that's what we do. That's our noble purpose. And I feel very fortunate to be able to have you on the program for the second time on this topic. And the good thing is that we have another topic. We've got number 3 coming up here in a few weeks that we will get on the books so that the ladies then can tune back in, and we're going to cover some other topics that are going to be of interest.
Yeah.
So we'll certainly figure out how to get more women to understand what's happening to their bodies and why it's so important to have hormones on board, because it's going to improve their quality of life and everyone around them.
And, at some point, maybe we can get something set up so that women can send in questions that we could do a podcast down the road and answer questions that have come through. And these aren't done.
Make that happen.
Yeah. I mean, these aren't done live, but they could send them to you. We could gather them up and then kind of try to go over them in a podcast 2 or 3 times from now. Right. So
absolutely. So all the ladies that are watching this, that are going to be watching this, that you share this with someone, friends, people that could benefit from this topic. You might not be there. You might already be managing your own hormones. Send those questions in. There's a link on our YouTube channel underneath the chat where you can ask those questions, and then we'll go through those prior to the show, and we'll grab some ones that we feel are relevant and really, broad in scope that might hit a lot of targets with it.
The other thing too is I hope you were able to get the compounding pharmacist information on there, because if they have a physician or a nurse practitioner, PA, physician assistant who wants to work with them but doesn't know where to get the medication, he can pretty well ship anywhere in the country. So so he's a great resource. He's a great guy. And compounding, which I don't know if we've gotten into yet, it's kind of like restaurants, right? It's all about the chef. So not every compounding company does hormones. And you want somebody who knows it, is familiar with it, who's done their due diligence in it, and he's very good. He's very service oriented, and he will assist any.
He's managing your hormones. If someone sends in something that seems a little bit obscure or something, he'll pick up the phone and call and say, "Hey, did you mean it to be this dose? I just want to confirm this is a little bit higher. This is a little bit lower."
Yep.
So he'll partner with the practitioner.
Absolutely.
To make sure the patient gets the best outcome.
And if the practitioner draws labs and the patient's just not absorbing for whatever reason, they can call him up and have a conversation, and he can help facilitate. Instead of drops, maybe they need a troche, something that a sublingual. So he will work with the provider without trying to take over, which is what I really respect. He's a resource. He has no interest in providing. He just wants to be a resource for the provider,
which is a great partner to have. And thank you. You'll see it on the screen. We'll drop it down in the chat, and certainly you can connect not only your provider, but you could connect with this particular gentleman to then, if it's something that could benefit you and give you a better quality of life, we are all about it. So Dr. Jarnagin, thanks for being on the program this afternoon. Always a pleasure, and wishing you the best, and can't wait to get to our session 3.
All right. I always enjoy it. Thank you so much for your willingness to get the word out on this topic.
Always.